see that it is slightly irregular, and it is. So this is rapidly conducted atrial fibrillation. And if you actually look at the speed of this, the rate is about 235 to 250 beats per minute. And that means, and what he does is he meets his VF criteria, so he gets a shock, but shocks don't usually do much for atrial fibrillation, so he goes into atrial fibrillation, and after a shock, he's even a little faster. Okay? And so he goes faster ventricular rate, gets another shock, goes even faster, and actually got 5 shocks, and then the device turns itself off. So how could you manage this? Well, first of all, awareness is there. You know, somebody who comes in who's febrile, has a defibrillator, you should know what his settings are. Once he gets a shock and you see this, you know, well, what could I do? Well, I could make his VF detection zone faster than 250 beats per minute, but that would mean I wouldn't treat something that occurred at 240 beats per minute. So you don't want to do that. We could turn the ICD detection off, which would mean that if he had a ventricular arrhythmia, he's likely to die, so you probably don't want to do that. An anti-tachycardia pacing is not going to help atrial fibrillation because the anti-tachycardia pacing is going to be in the ventricle, so it's not going to do that. And you probably don't want to leave him there getting shocks every 30 minutes or so. So what you have to do is you have to turn his detection off, but now you have to be prepared to manage ventricular arrhythmias if they occur, which would not be uncommon in an 82 with pneumonia. So you have to put him in the ICU. You can't leave him on the floor bed. So I think the answer here is 3. You have to think through every part of the question to get to the right answer. Okay, next. The patients in my questions get older and older every year. You know, we now have it, but I think the patients in your ICUs get older and older every year, so it's probably appropriate. An 85-year-old woman with urosepsis develops tachycardia. She has 2 ECG patterns without any intervening periods of sinus rhythm during the next 10 minutes, and I want you to tell me what the diagnosis is. Here's ECG 1, and there's ECG 2. 1, 2. Okay, so is this VT and sinus tach? Is this VT and AV node reentry? Is this AV reentry with normal and aberrant QRS complexes? Atrial flutter tachycardia with 2-to-1 and 1-to-1 conduction? Or is it pre-excited atrial flutter and sinus tach? And so I'm going to give you the first tracing. Let you look at that for about 30 seconds. And the second tracing, let you look at that for about 30 seconds. And now we can start the clock. Great. So almost half the group got it right. And let's go over it again. So let's look at the first tracing. Whoops, I'm sorry. Let me go back to the first tracing. So this is ECG 1, and you have to look at it very carefully, and you have to try to figure out what's going on. And if you look carefully in V1, and you probably won't see it in your printout, and you may not see it at this distance, but there are little negative P waves there in a 2-to-1 relationship to the QRS complexes. If you look over here in the inferior leads, you can't really have two P wave. This is very short for a T wave. This is very short for a PR interval. These are actually flutter waves or atrial tachycardia P waves, and they're again in a 2-to-1 relationship. And if you look again very carefully up in V1, you have that. Notice that this woman has a right axis deviation. She's got a negative deflection over in one, and she sort of has, it's sort of one of those indeterminate left corner axes there that she has. So if you go to the next tracing, well, then we have to say, well, this is exactly twice the rate of the prior tracing. And now she has a left bundle type pattern. We don't see individual P waves anymore because the QRS is so wide and so rapid, or at least we can't see them with any certainty. But the fact that it's occurring at the same time, it's exactly twice the rate, and the QRS is sort of an exaggeration of the pattern you saw on the prior tracing, tells you that this is atrial flutter with 2-to-1 and 1-to-1 conduction. And again, one of the things we have to worry about in the intensive care units is very rapid rates in these atrial arrhythmias because the patients are so adrenergically stressed, and frequently things like their beta blockers and other things may get held, or because their pressures at baseline are borderline. The other point, from a test-taking point of view, when you see two rhythms in the same 10 minutes without something in between, think it's one rhythm with two manifestations rather than two different rhythms. Okay. Case 10. 79-year-old woman underwent a right coronary stent complicated by transient closure during the procedure. Several hours later, she developed the rhythm shown. She's resting comfortably and is unaware of her rhythm. And I'm asking you what you should do. This is her rhythm. Do you want to repeat coronary angiography urgently, rush her back down to the cath lab? Lidocaine, amio, temporary pacemaker, or routine intervention protocol? Okay, we can start the clock. Great. Most people got it right. So this is, this is the classic accelerated idioventricular rhythm. It's a wide complex rhythm, relatively modest rate. The rate's about 110 beats per minute. I actually can't see atrial activity here, but this is pretty classic for accelerated AIVRs in that they sort of start up and then go for a couple of beats, then stop, then go for a couple of beats, then stop. And the setting is she had a complicated percutaneous intervention. There probably was some myocardial injury. This is probably some dying cells that are just expressing some automaticity before they roll over and die. But it's a very common situation. Doesn't require anything, benign prognosis. If you treat it, you're likely to get into more trouble than it's worth. Okay, case 11. 82-year-old man is admitted after a syncopal spell. He has hypertension. He has good left ventricular function and mild left atrial enlargement. Initial ECG was normal, but in the emergency room, the rhythm strip shown was obtained. What would you recommend next? And there's your rhythm strip, so we need some time for this. Okay, so what would you recommend? Should he get an ICD, dual-chamber pacemaker implant, EP study, outpatient event recorder, or coronary angiography? And we can start the clock. Great. Again, most people got the answer right. So let's go through the rationale. So what do we see on the tracing? Remember, this is an 82-year-old man with syncope. He has good ventricular function, so the likelihood that this is a ventricular arrhythmia is low or lower. And he has an abnormal cardiogram. And what does the cardiogram show? Well, we see 3 to 2 AV block here. And then the second beat in each sequence has shows a bundle branch block. And that is, the setting makes it very suggestive that this is block in the His-Purkinje system. And block in the His-Purkinje system, particularly in a symptomatic patient, is associated with a high risk of progression to at least intermittent AV block. And so syncope, no other likely cause, very high risk electrocardiogram. You'd go ahead, you'd put a pacemaker in, and then see how he did. You could do an electrophysiologic study, but it would be unnecessary, really. This is enough. An outpatient event recorder, well, with this, you wouldn't send him out. ICD, it's always, an ICD would treat this as well, but it's not really specific, and he probably doesn't need the defibrillation function. And coronary angiography is sort of irrelevant to this situation. So you'd sort of, again, what you want is the most specific treatment that's directed at the abnormality you see. Okay. 55-year-old woman is brought to the coronary care unit with hypotension and chest pain of 90 minutes duration. Her ECG is shown. She's gotten heparin, metoprolol, aspirin, and nitroglycerin. What's the best next step? You've already seen this tracing. I've already told you the answer, so we can just start the clock and see how well you remember it. We're going to go for 100% right on this one. Whoops. Okay. Well, again, let's go back onto the history. So here our situation is she's a normal sinus rhythm and she does have QT prolongation, but she's hypotensive and she's having chest pain. So there's no rhythm actively to treat right now, and she's having chest pains, and she's in sinus rhythm. So you have to say, well, why is she having chest pain, and why is she having all this? It's got, at least you're very, very pressed to rule out that this is not ischemia. And this is sort of the typical stunning we see with diffuse myocardial ischemia, in which you have intermittent closure of a vessel. Or intermittent subtotal of a vessel. And in fact, when we did take her to the cath lab, she had a total right coronary occlusion, and you may not be able to see this, but there's a very tight proximal left main lesion right here. And so when you see this situation, remember QT interval prolongation, chest pain, hypotension, the most important thing you got to rule out right away is ischemia. And she was actually taken to the cath lab, a balloon pump was put in, she went to the operating room and came out a week or two later with normal ventricular function and a normal cardiogram. And you just have to think exactly what you're doing, and the history, read the stem very carefully. Don't focus just on the cardiogram. Okay. 79-year-old woman with a history of rheumatic fever has begun on an antiarrhythmic drug in an attempt to convert atrial fibrillation. Shortly after conversion, the rhythm strip shown was obtained, and I'm going to ask you which drug she was probably given. Was it lidocaine, flecainide, amiodarone, dofetilide, or metoprolol? Okay, we can start the clock. Ooh. Okay. Well, let's go. First of all, let's look at the case. 79, woman, valvular heart disease, atrial fibrillation. Without even thinking about it, if it's an arrhythmia question, it's going to be, this is a question about Torsades, because these are all risk factors for Torsades de Pont. She's elderly. Women have about 3.5 times the prevalence or the incidence of Torsades. People with valvular heart disease have a history of Torsades or a risk for Torsades that's 2 or 3 times normal, and antiarrhythmic drugs are the most common cause. And it's usually in the setting of atrial fibrillation, not VT. So all of those things tell you that this is likely to be Torsades, and you haven't even seen the cardiogram yet. Now you look at the cardiogram, and this is Torsades. Remember, Torsades, polymorphic VT with a long QT interval. Look at this QT interval here. I mean, that QT interval is gigundum. It's like 800 milliseconds if you saw it. And then you have the twisting of the points, spontaneous termination, and you're back over here, okay? So clearly, Torsades de Pont, high-risk individual. That's why we bring him into the hospital. Then you have to say which drugs are likely to cause that. Well, lidocaine is a relatively weak sodium channel blocker, doesn't cause Torsades. Flecainide is a sodium channel blocker, fairly potent. In atrial fibrillation, Torsades, it's not its major mechanism. As a matter of fact, even though it's been described, it's not commonly seen. Doesn't really prolong the QT interval. If I showed you atrial flutter with one-to-one conduction, you might think flecainide, but Torsades would not be high on your list. Amiodarone does prolong the QT interval. Rarely has been associated with Torsades, but it's fairly uncommon. So there, but not the highest on the list. Metoprolol, not associated with QT prolongation, not associated with Torsades, off your list. Dofetilide. Dofetilide's an antiarrhythmic drug. It's an IKR blocker. The major effect of blocking IKR is to prolong repolarization. Its most common toxicity is Torsades. In fact, almost its only toxicity is Torsades de Pont. It's so toxic that we require people to stay in the hospital for 3 days and get their QTs measured every couple of hours. So, again, going down the list, knowing what the toxicity is, knowing what the arrhythmia is, dofetilide's your only choice. So, dofetilide. Okay. And I think this is my last one. An 83-year-old man received a dual-chamber pacemaker 7 months ago for intermittent AV block. The pacemaker set in DDD mode with a lower rate of 50. He now presents with 2 episodes of syncope. His ECG is shown. It's going to take a while for people to look at this one. Okay, we can start the clock. Okay, most of you thought it was atrial and ventricular lead malfunctions. That is actually not correct. But part of that may be because it's hard to see on the tracing. If you had really this tracing in front of you, it'd probably be easier to see. So let's look what's going on. When you look, you want to see, if there's a P wave, is there a response to it, which tells you that you're atrially sensing correctly? And if there's a pacing spike, is there a QRS or a P wave after it? So here we have a pacing spike, which is a P wave, which is an atrial pacing spike, and there is a very small QRS after it, or P wave after it. I admit it's small, but you can see it when you have the full tracing. And then over here, you have a P wave with a pacing spike after it, so that there is a response to a P wave. So we both atrially sense and atrially capture. But we have these other spikes, which are not associated with a QRS complex. So we have here, and you can see over here, there's a P wave, pacing spike, no capture, PVC, PVC, atrial pacing spike, small P wave, so you've captured, no capture. So this is ventricular loss of capture. And so this is just a ventricular lead malfunction. The atrial lead is actually working well. It's not a generator problem. It's not both leads malfunction. But again, if you're trying to look at it from a distance, this is going to be hard to see. You'd really have to look very carefully. And just to show you some of the useful things, if you interrogated this device, this is a plot of ventricular lead impedance, and the normal value should be under about 1,400 ohms for this lead. And you can see that very abruptly, after several months of implant, this impedance climbs dramatically. So he's developed scarring around the tip of the lead. He can't put out enough energy to capture. He loses capture. And so all we had to do was replace the ventricular lead. Thank you.